Usually when we talk about a medical diagnosis, there's like this expectation of absolute precision.
Yeah, like it's totally clear cut.
Exactly. I mean, you break your arm,
Yeah.
the x-ray shows that jagged white line, and the doctor just points and says, there it is, broken or not broken.
It's very binary.
Yeah, and we find a lot of comfort in that visibility. But step into the world of national healthcare systems, and suddenly that x-ray machine is, well, it's completely useless. We're looking at a diagnostic landscape that is incredibly murky.
Oh, absolutely.
So welcome to this custom-tailored deep dive, where our mission today is to unpack how the world's oldest universal healthcare system actually works. We're looking at how it aggressively keeps costs down and, the hidden, highly controversial trade-offs it makes just to survive.
We are, of course, talking about Germany.
Right.
And we are pulling from a really phenomenal stack of sources to do this for you today. We've got historical archives detailing the somewhat cynical origins of the system.
Very cynical, yeah.
We also have a deeply critical legal analysis by researcher Heidi Nadolski. She looks at how medical care is actually distributed. Plus, we've got pharmaceutical pricing briefs from the Berkeley Center for Health Technology and, crucially, breaking news from July 2026 regarding this massive, highly contentious legislative overhaul.
Yeah, the paradox we are looking at today is just staggering. On paper, the German system boasts some of the lowest wait times, highest accessibility in the developed world.
Unbelievable access, really.
Right. Yet, you look under the hood today and you find a system facing a projected €6.25 billion deficit. It's fighting off accusations of widespread, hidden rationing and sitting right at the center of a global geopolitical showdown over drug prices. Okay, let's unpack this, because before we can begin to comprehend the crisis they are facing right now in 2026, we have to understand the 140-year-old machinery of this system. We're going to go back to 1883.
Right. It all starts with Chancellor Otto von Bismarck. Now, Germany operates the world's oldest national social health insurance system, but the motivation behind its creation completely defies, modern expectations.
How so?
Well, Bismarck did not establish universal health care out of some deep, altruistic devotion to the working class.
He wasn't just being a nice guy.
Not at all. He engineered it as a political weapon. During the 1880s, the Democratic Socialists were gaining immense traction among German workers.
Okay.
So Bismarck realized that the most effective way to neutralize a socialist movement was to basically co-opt their biggest selling point.
So he essentially used the power of the state to say, look, we can provide you with a safety net. You don't need a socialist revolution to get it.
Exactly. It was a highly calculated maneuver to maintain imperial control while stabilizing the workforce. And the architecture he designed reflects that absolute pragmatism.
Right. And it's vital for you listening to understand that Germany is not a single-payer system. I mean, we aren't talking about the beverage model used in the UK.
Right, where the government owns the hospitals and directly employs the doctors.
Yeah, that's not Germany. Germany relies on what is literally known as the Bismarck Model, which delegates the administration of health insurance to what they call sickness funds.
Sickness funds, yeah.
Working alongside private medical providers.
And those sickness funds, even though they sound like something out of a Dickens novel, they are very much the engine of the modern system.
How many are there?
There are about 110 of them operating today. They function as decentralized, nonprofit entities, and the way this is funded is through a strict 14.6% payroll deduction.
But the individual worker doesn't pay all of that, right?
No, the worker doesn't bear that full weight. It is split equally, straight down the middle between the employee and the employer.
Okay.
And one of the most significant elements of this funding structure is that this single contribution covers dependents. So non-working spouses and children are covered at no additional cost.
Which is huge. But this structure creates a massive divide in how the population is insured. About 88% of German residents are enrolled in this statutory public system, which is known as the GKV.
Right, the vast majority.
Yeah. And another 11% are in the private system, or the PKV. But it's not like a free market free-for-all, right?
Yeah.
You can't just opt out of the public pool because you want fancier waiting rooms.
No, absolutely not. You are legally mandated to participate in the public GKV system unless you meet very specific exemptions.
Like what?
Well, you have to be a freelancer, a civil servant, or you must earn over a rigid income threshold. As of 2026, that opt-out threshold sits at €77,400 a year.
Okay, so visualizing this structure is key to understanding its vulnerabilities. You can kind of think of the German public system as a massive, legally mandated co-op board.
Oh, I like that analogy.
Right. The wealthy are actively paying for the poor. The healthy are subsidizing the sick, and the young are financing the care of the elderly.
What's fascinating here is that this operates on the foundational principle they call solidarity. And this solidarity model is incredibly effective at generating accessibility.
The numbers back that up, too.
They do. Data consistently shows that 70% of Germans wait less than 1 month for elective surgeries.
Wow.
Yeah, they have abundant hospital capacity and a tremendous density of physicians compared to similarly developed nations.
But the critical mechanism that keeps this co-op running is that it operates on a strict pay-as-you-go basis.
This is crucial.
There is no sovereign wealth fund for healthcare. The euros collected from workers' paychecks this month go straight out the door to pay for MRI scans and insulin this month.
Right. The public sickness funds do not sit on massive long-term reserves to weather future storms.
So the moment healthcare costs begin to outpace wage growth, the entire engine starts redlining.
Which logically forces the sickness funds to become utterly ruthless about cost control. I mean, if you have no cash reserves and you politically cannot afford to increase that 14.6% payroll tax without crippling the working class, you have to find savings somewhere else.
And what's the biggest target?
Pharmaceuticals. It's the largest, most volatile line item in modern healthcare. Germany's approach to the pharmaceutical pricing dance is honestly one of the most aggressive and fascinating mechanisms in the world.
Let's look at how this plays out, because the initial phase almost sounds like a pharmaceutical executive's dream. When a new drug is authorized for the European market, the manufacturer actually gets to launch it in Germany at whatever price they want for the first year.
Whatever price they want.
Yeah, they completely dictate the cost.
For 12 months, they have total pricing freedom. But the moment that drug hits the market, a ticking clock starts, and the German regulatory apparatus activates.
Okay, break that down for us.
There are two major entities at play here. First, you have IQWIG, which is an independent scientific institute responsible for evaluating the raw clinical data.
They do the heavy scientific lifting.
Exactly. They compile a massive dossier on the new drug. Then you have the GBA, or the Federal Joint Committee. This is the supreme decision-making body comprised of representatives from the physicians, the hospitals, and the sickness funds.
So what does the GBA actually do with that dossier?
They take it from IQWIG and ask one highly specific question. Does this new drug offer an added clinical benefit compared to the current standard of care?
Right. They aren't just looking at whether the drug is safe or effective in a vacuum.
No, not at all.
They are looking at the mechanism of action and asking, like, does this extend life longer than the pill we bought 5 years ago? Does it significantly reduce severe side effects?
Exactly. And if the drug actually proves an added clinical benefit, the system shifts into a high-stakes negotiation.
This is where it gets intense.
Very. The manufacturer must sit down with the sickness funds to hammer out a permanent reimbursement price. And this is set up as a bilateral monopoly.
Meaning what?
You have a single buyer acting on behalf of 90% of the German population, staring down a single seller who holds the patent.
Okay, but what if those two massive entities just cannot reach an agreement?
The system doesn't just let the drug sit in limbo.
Yeah.
It goes to a binding arbitration panel, which literally forces a price upon them.
And the stakes there are incredibly high, right?
Unbelievably high. Over one recent 6-year period, 35 different drugs went to this binding arbitration. In 30 of those cases, the pharmaceutical manufacturers were so unhappy with the arbitrated price that they pulled the drugs from the German market entirely.
Wow. 30 out of 35. That is a staggering attrition rate.
It really is.
But here's where it gets really interesting for me. If I'm looking at this from a business perspective, it raises a huge question. If I'm a global pharma giant and I've poured billions of dollars into developing a therapy, only to be told my drug doesn't offer enough added benefit to justify my price tag, why stay engaged at all?
That's the million-dollar question.
Right. Like, why don't more companies just refuse to launch in Germany and take their ball and go home to focus on more lucrative markets?
Well, the leverage the German system holds is purely geographical and economic. Germany is the single largest healthcare market in Europe. Refusing to play ball means abandoning a massive revenue stream.
Which no CEO wants to do.
Exactly. Furthermore, the European pharmaceutical landscape is deeply interconnected. The price negotiated in Germany often acts as a benchmark for surrounding nations.
Ah, so it sets the standard.
It does. But beyond the math, there is a huge cultural element. The German system operates on collaboration. If a massive pharmaceutical corporation takes their ball and goes home, they cultivate a non-collaborative reputation.
And that's bad for business down the road.
It's corporate suicide. When they inevitably return 3 years later with a different blockbuster drug, The GBA remembers. You do not want to alienate Europe's biggest buyer.
Right. And we also have to look at what happens to the drugs that fail the GBA's test entirely.
Yes, the Me Too drug.
Yeah, if the reviewers decide a new medication has no added clinical benefit, if it's just functionally identical to something already off patent, it gets thrown into a mechanism known as reference pricing.
How does that work?
Well, the sickness funds look at every similar drug in that therapeutic class, rank them by cost, and draw a hard line at the 30th percentile.
Wow, just the 30th.
Yep, that becomes the absolute maximum reimbursement limit. The sickness fund will not pay a single euro beyond that 30th percentile mark.
This creates a fascinating behavioral economics scenario. Because if the pharmaceutical company insists on charging a price higher than that 30th percentile limit, the legal burden of paying the difference falls entirely on the patient.
But wait, German citizens aren't used to paying big medical bills, are they?
No, the German system is designed to heavily shield citizens from medical debt. Out-of-pocket medication costs for patients are strictly capped by law at 2% of a household's annual income.
2%.
That's so low. And it's just 1% if the patient has a chronic illness.
Okay, so you have a population completely unaccustomed to footing large medical bills. When the pharmacist tells a German patient they have to pay a massive surcharge because the manufacturer priced the drug above the reference limit, the patient simply refuses.
Right, they just say no.
They walk back to their doctor and ask for the cheaper alternative that falls under the sickness fund's umbrella. The consumer pressure is so intense that in 84% of these cases, the pharmaceutical companies voluntarily drop their prices below the reference limit,
84% of the time.
just to avoid losing the market share entirely.
It is an incredibly potent cost control mechanism. It essentially forces a race to the bottom for redundant therapies, while theoretically preserving capital for true innovations.
But even with this ruthless efficiency, you can't defy the laws of economic gravity forever.
No, eventually the bill comes due.
Right. When you have a pay-as-you-go system with strict revenue limits tied to payroll taxes and an aging population continually demanding more complex care, the mathematical reality breaks down.
The money eventually runs out before the fiscal year is over.
And when the math breaks, someone, somewhere, does not get treated, which pushes the system out of the realm of public policy and into the hidden realities of hospital corridors.
Yes. And this is where Heidi Nadolsky's research completely upends the idealized vision of the Bismarck model.
What has she found?
In her critical legal analysis, Nadolsky establishes a baseline truth. Any healthcare system dealing with finite resources must engage in rationing.
It's inevitable.
Totally. The debate is never about if a country rations care, but solely about how they do it.
Okay, so how does she break that down?
She categorizes rationing into distinct tiers. You have hard rationing, which involves illegal acts, such as the black market trading of organs.
Yikes, okay.
Then you have soft rationing, where patients use their private wealth to bypass the public system entirely. For example, a German citizen taking a medical tourism trip to Eastern Europe to purchase high-end dental implants because the GPC will only cover a very basic standard.
Right, that makes sense.
And then you have open rationing, where the limitations are transparent, debated publicly, and known to all citizens.
But Nadolsky's primary target is this insidious practice of hidden rationing, right?
Exactly.
This occurs when doctors and hospital administrators quietly deny or delay medically necessary care in order to stay under their strict budgets. And they do this all while keeping the patient completely in the dark about the true motivation.
It's crucial to understand the mechanism driving this, too. In Germany, physicians are allotted specific budgets per patient profile for each quarter.
Okay.
If a doctor prescribes therapies or medications that exceed this budget, they can face a process called regress.
Regress. Wait, what does that actually mean for the doctor?
It means they could be held personally liable to reimburse the sickness fund for the overage.
You're kidding. Personal liability for prescribing too much.
Yes. That financial threat creates a profound conflict of interest. The physician is no longer just a healer. They are forced to act as a stealthy accountant for the sickness fund.
Wow. And the real-world consequences detailed in her research are just sobering, like the example of pediatric speech therapy.
Right, that one is heartbreaking.
A doctor realizing they are dangerously close to their quarterly budget limit might simply tell a parent to postpone their child's remaining therapy sessions until the next budgetary year.
They just frame it as a scheduling thing.
Exactly. They present this as a normal scheduling issue, even though interrupting the therapy is medically counterproductive. Nadolsky also points to multiple sclerosis as a stark example of this dynamic.
Yeah, the interferon case.
Right. There is this modern drug called interferon, which is highly effective for MS patients, but it carries a price tag of around $13,500 a year.
Which is a huge hit to a doctor's quarterly budget.
Exactly. Because of the intense pressure to stay under budget, Nadolsky notes that only about 20% of MS patients in the system actually receive this modern treatment.
So what happens to the other 80%?
The remaining 80% are quietly steered toward older, cheaper, suboptimal drugs. The doctor simply manages the patient's expectations downward. They never disclose that a superior therapy was withheld for purely financial reasons.
It's awful, and we see this rationing extending into the physical infrastructure of the hospitals, too.
How so?
While capped hospital budgets inevitably result in severe understaffing, the remaining physicians are pushed to their absolute limits, working an estimated 50 million hours of unpaid overtime across the system.
50 million hours.
Yeah. You have surgeons working 20-hour on-duty shifts without a break. And when exhaustion scales to that level, medical errors inevitably increase.
Of course they do.
Nadolsky also highlights cases where sickness funds flat out refuse to authorize vital treatments,
Like what kind of treatments?
like essential physiotherapy for stroke rehabilitation. They just deny it, simply to protect their bottom line and keep their premium rates politically favorable.
So, to use an analogy, it's like going to a restaurant that doesn't tell you they're out of steak. They just serve you chicken and insist it's actually better for you anyway.
That is exactly what it's like.
So what does this all mean for the patient? I mean, is it ethical to ration behind closed doors just to balance a spreadsheet?
Well, this raises an important question, right? Nadolsky argues that hidden rationing excludes the patient from the allocation process entirely.
It destroys informed consent.
Completely. It allows arbitrary expenditure-based limits to override clinical necessity without any societal oversight. If a society is going to ration care, which, again, it mathematically must, Nadolsky argues it has a moral imperative to do so openly.
Yeah, and for decades, the German system actually managed to keep these hidden cracks relatively quiet. The solidarity model somehow absorbed the strain.
But a system built on the premise of young workers paying for the care of the elderly requires a constant supply of young workers.
Which brings us to the demographic tipping point. The foundational math of the Bismarck system is actively collapsing, leading us directly to the massive legislative actions of July 2026.
Yes. The demographic time bomb isn't a future threat anymore. It has fully detonated.
Give us the numbers on that.
By the year 2050, projections show that 1/3 of the entire German population will be over the age of 60.
A full third.
Yes. So the workforce is shrinking while the elderly population requires increasingly complex, expensive interventions.
And because this is a pay-as-you-go system with no long-term reserves, the public sickness funds found themselves staring down a catastrophic €6.25 billion deficit in early 2025.
The solidarity mechanism simply ran out of money.
So the political response had to be monumental. On July 13, 2026, Chancellor Friedrich Merz pushed through one of the most severe welfare state reforms in modern German history.
The goal was to forcefully extract 16 billion euros in savings.
And the mechanisms of this reform are incredibly aggressive. First, they severely cap the costs that hospitals are legally allowed to pass on to insurers.
Which effectively means hospitals have to absorb the impact of inflation and wage increases themselves.
How do they even do that?
They cut. To survive, hospital administrators are forced to cut non-essential services, delay purchasing modern diagnostic equipment, and stretch their already exhausted staff even thinner.
Wow. The reform also significantly increased the mandatory rebates that pharmaceutical companies must pay back to the sickness funds, right?
It did. But the most explosive mechanism in the MERS reform is a new macroeconomic cap.
Right. This is wild. Future healthcare spending increases are now strictly tied to the overall growth of the German economy.
Exactly. So if the GDP stagnates, the healthcare budget freezes. It doesn't matter how many citizens get sick or what amazing new therapies are invented.
This fundamentally changes the economic reality for global health companies operating in Germany.
Overnight, the reaction was immediate. Eli Lilly, one of the world's largest pharmaceutical companies, publicly announced they are scaling back their manufacturing footprint in Germany.
Just like that.
Just like that. They directly cited the hostile pricing environment, and they are redirecting those capital investments to the United States.
And this domestic budget crisis has rapidly escalated into a major geopolitical conflict. The United States Trade Representative under President Trump actually launched an official high-level investigation into Germany's healthcare reforms.
Yeah, this became international news.
The USTR argues that Germany's price controls and mandatory rebates are inherently discriminatory against foreign innovation. The core of the American argument is that Germany is systematically underpaying for the billions of dollars American companies spend on research and development.
They're essentially arguing that U.S. consumers are forced to subsidize the cheap medications that German citizens enjoy.
Right. Now, it is vital for us to note that we are looking at this strictly through the lens of our source material. We are not endorsing a side in this trade war. We are just reporting what both sides are claiming.
Absolutely. We have to stay impartial here. The facts lay out a deeply entrenched binary standoff. The German government, led by Chancellor Merz, argues these draconian caps are the only mathematical way to prevent insurance premiums from hyperinflating and crushing the working class.
They view it as an existential defense of the Bismarck welfare state.
Right. But on the flip side, the pharmaceutical industry, fiercely backed by the U.S. government, points out that tying healthcare spending to GDP growth mathematically caps the upside for innovation.
Which is a valid point, economically speaking.
They argue these policies will devastate the development of new drugs, eliminate thousands of high-tech jobs, and ultimately ensure that German patients are denied access to the next generation of life-saving therapies.
If we connect this to the bigger picture, it's truly fascinating to look at the macro view here. Otto von Bismarck designed this system in 1883 as a domestic political tool to fend off a local socialist movement. And today, that exact same structural machinery has evolved into a global flashpoint affecting international trade tariffs and the flow of billions of dollars in medical innovation.
It is an ecosystem defined by the constant friction between the promise of universal solidarity and the harsh reality of finite resources.
Exactly. So let's synthesize this journey. The German healthcare system is a brilliantly complex 21st century machine built on a 19th century foundation. It successfully delivers phenomenal access and short wait times to tens of millions of people through a decentralized co-op model.
It does work for a lot of people.
It does. But that success is not magic. It relies on the quiet, hidden rationing of care by physicians trapped by budgetary threats, and it demands an aggressive, hardball approach to pharmaceutical pricing that is now literally sparking international trade wars.
It's all connected.
So here's the takeaway for you listening right now. Whenever you hear politicians in any country promise the dream of universal coverage with low out-of-pocket costs, I want you to remember the mechanics of Germany, because that promise always requires a sacrifice.
You have to ask the hard questions.
Right. Where is the hidden rationing occurring? Who is making the compromises behind closed doors to balance the spreadsheet? Is it the physician forced to delay therapy, the patient quietly receiving the older drug, or the manufacturer forced to take a loss?
And I want to leave you with one final unexplored thought to ponder on your own.
Go for it.
We have dissected how the aging demographics are cracking the system today, but project this forward. As the math of a shrinking workforce supporting a massive elderly population becomes increasingly impossible to solve with just budget caps and drug rebates, what happens when the money simply stops?
What do you mean?
If the pay-as-you-go engine eventually runs completely out of young people to tax, will the foundational concept of solidarity that Bismarck invented 140 years ago be forced to collapse into total privatization?
Wow. From the flawed clarity of an X-ray to the potential collapse of a national ideal, that is a heavy structural question to chew on.
It really is.
Well, thank you so much for joining us on this deep dive into the hidden mechanisms of the German healthcare system. Keep asking those hard questions, and we will catch you next time.